Let's take a look at the gross anatomy of the heart. The heart is located within the mediastinum. It is situated posterior to the sternum and anterior to the vertebral columns. It is cone-shaped and the size of a clenched fist. The layers of the heart wall from superficial to deep are the epicardium, which is the inner layer of the pericardium, the myocardium, which is the muscle layer of the heart responsible for pumping the blood, and the endocardium, which is the endothelial tissue that lines the valves and chambers. The heart has four main chambers: the right atrium, the right ventricle, the left atrium, and the left ventricle. The myocardium or muscle tissue is thicker in the ventricles. This is because the atriums fill with blood while the ventricles pump blood. The left ventricle has the thickest myocardium because it's pumping blood to the entire body. The heart's great vessels include the superior and inferior vena cava, aorta, pulmonary veins, and the pulmonary trunk. So what's the functional difference between arteries and veins? Arteries carry oxygenated blood from the heart towards the body at high pressure. Veins carry deoxygenated blood from the body to the heart at a low pressure. So how does the heart ensure that blood flows in only one direction? Through valves located between the ventricles and atria. The tricuspid valve is between the right atrium and right ventricle. The bicuspid or mitral valve is between the left atrium and left ventricle. The pulmonary valve is between the right ventricle and pulmonary trunk. And the aortic valve is between the left ventricle and the aorta. The opening and closing of valves is due to the pressure differences across the valves. The chordae tendineae and papillary muscles are essential as they hold the cusps of the valve down, preventing blood from going backwards through the AV valves into the atrium. Just like any other organ, even the heart requires oxygen. The left and right coronary arteries arise from the ascending aorta and branch to supply all of the heart's muscle tissue. These little branches, or anastomoses, ensure that the blood is delivered to the heart even if there's an occlusion. The heart removes waste through coronary veins. The forming cardiac veins are small anterior, great, and middle cardiac vein. These drain blood away from the myocardium, and all the veins drain into the coronary sinus that empties into the right atrium.
The cardiac conduction system is a group of muscle cells found in the heart walls that send signals to the rest of the heart, causing it to contract. The SA node initiates the impulse which spreads to the muscles of the atria, causing them to contract. The AV node detects this impulse from the atria and conducts it to the AV bundle, and then to the right and left bundle branches. The signal is then passed on to the Purkinje fibers, turning it upward and spreading throughout the ventricles, causing them to contract. An ECG is used to record all the impulses that take place in the conduction system. The P wave is known as atrial depolarization. This is when the atria fill with blood. The SA node sends electrical signals throughout the atria, causing it to depolarize. The distance between the P and Q is the amount of time that the signal travels from the SA node to the AV node. QRS complex is known as ventricle depolarization. This is when the electrical signal reaches the AV node. The distance between the S and T is the plateau in action potential. This is when the ventricles contract and pump blood. The T wave is known as ventricle depolarization. This is when the ventricles relax and the cycle starts over.
The cardiac cycle consists of all the events that take place from the beginning of one heartbeat to the beginning of the next. Systole refers to contraction, while diastole refers to relaxation. The events of the cardiac cycle occur in response to pressure changes. The blood follows a path moving from areas of high pressure to lower pressure. We will see that pressure changes are what trigger the valves to open or close as we move through the cardiac cycle. Now, let's take a closer look at the phases of the cardiac cycle. First, we begin with the passive filling phase. As the name implies, the ventricles are being passively filled with blood. The atria are relaxed and are being filled with blood from the superior and inferior vena cava and to the pulmonary veins. The atrioventricular valves are open, allowing the blood to flow passively into the ventricles, while the semilunar valves are closed. As a result, the pressure within the atria begins to rise. This passive filling accounts for about 75% of the blood that will enter the ventricles. The next phase is atrial contraction. In this state of atrial systole, the atrioventricular valves continue to remain open. The atria contract, thus forcing the remaining 25% of the blood into the ventricles. The semilunar valves remain closed. This now brings us to the phase ventricular isovolumetric contraction. The atria are relaxed, and as the atrial pressure drops, the atrioventricular valves now close, which in turn produces the first heartbeat sound. The semilunar valves are also still closed. This creates the condition for an isovolumetric contraction of the ventricles. Isovolumetric means that no change in the volume occurs. A volume change is not possible because both the atrioventricular and semilunar valves are closed. As the ventricles begin to contract, pressure within the contained chamber begins to rise. The next phase of the cardiac cycle is ejection. The semilunar valves now open because the pressure in the ventricles is greater than the pressure in the aorta and pulmonary arteries, thus allowing for ventricular ejection to occur. The ejection is initially rapid due to the pressure in the ventricles. This is followed by a slower rate of ejection as the pressure decreases. The atrioventricular valves remain closed and the atria are relaxed. The final phase is ventricular isovolumetric relaxation. The atria remain relaxed and the semilunar valves close because now the pressure in the ventricles is less than that of the aorta and pulmonary artery. The closing of the semilunar valves creates the second heartbeat sound. With all of the valves closed, the volume in the ventricles does not change. Therefore, isovolumetric relaxation in the ventricles occurs.
Dilated cardiomyopathy has two conditions, one being the enlargement or dilation of one or both of the ventricles, though it normally starts in the left ventricle, and having a left ventricle ejection fraction of less than 40%. Left ventricle ejection fraction is when you take the stroke volume, which is your end diastolic volume minus your end systolic volume, divide that by your end diastolic volume and times it by 100. Normal range is between 50 and 70%. What causes dilated cardiomyopathy? It initially begins with the weakening of the heart muscle cells, or the cardiomyocytes. Therefore, your heart is not able to contract as efficiently. Your body detects the lower left ventricle ejection fraction as it's not receiving an adequate amount of oxygen. To compensate, it dilates your left ventricle to increase its volume. The increase in blood flow into the left ventricle temporarily increases your stroke volume. But with this increased volume comes increased pressure on the heart muscles. So, the heart continues to compensate by dilating the left ventricle and eventually the right ventricle. Eventually, your cardiomyocytes become so thin and so weak that it can no longer maintain contracting to pump your blood throughout your entire body. This is what causes dilated cardiomyopathy to become systolic heart failure. This weakness also causes the bicuspid and tricuspid valves to not close completely with each contraction. This allows backflow of blood into the atriums, which then leads to a lot of symptoms that are associated with dilated cardiomyopathy. Symptoms seen in dilated cardiomyopathy include edema and ascites. Both are due to fluid buildup in the body, which leads to swelling. Edema is mostly seen in the lower extremities. This is because the left ventricle isn't able to sufficiently pump blood throughout the entire body, causing blood to pool in the legs. Ascites is due to the backflow into the right atrium, which increases the pressure on the veins, especially the hepatic vein and the veins that drain the peritoneum, which is a serous membrane of the abdominal cavity, leading to swelling there. Next, you're going to see shortness of breath. This is due to the backflow into the left atrium. As we know, the lungs connect to the left atrium through the pulmonary veins. Therefore, fluid builds up the lungs. This is especially seen during exertion and exercise. It can also cause orthopnea, which is the feeling of shortness of breath in the lying down position. It can also cause paroxysmal nocturnal dyspnea, which is random feeling of shortness of breath in the middle of the night. You're also going to see fatigue in these patients. As we know, blood brings oxygen to different parts of the body. If the body's not receiving enough oxygen, therefore you're going to have this overall feeling of tiredness. You're also going to see lightheadedness and dizziness. In extreme cases, it may also cause fainting. For similar reasons, as we know, blood brings oxygen. That just means the brain is not receiving enough oxygen. Finally, you're also going to see irregular heart rhythms and sounds. So because we know that SA node sends the electrical impulses to the left ventricle, because the left ventricle is so dilated, it can cause a delay in this, which causes a delay in the contraction, which leads to irregular heart rhythm.
You're also going to hear an irregular heart sound. It's commonly called the S3 sound. This because there is so much blood because the left ventricle is so dilated that the actual sound of the blood hitting the apex of the heart creates the S3 sound. Though most cases of dilated cardiomyopathy are idiopathic, meaning they're unsure of the cause, there are common risk factors that can be seen. So certain genetics, toxic substance abuse, including cocaine, alcohol, certain medications, infections, including myocarditis. Pregnancy has also been associated with DCM, and along with certain endocrine, metabolic, and autoimmune diseases. Treatment options for dilated cardiomyopathy include lifestyle changes, so minimizing some of those controllable risk factors that I mentioned earlier, including toxic substance abuse, if you're able to switch your medications. Then those mixed with usually other medications, include diuretics, ACE inhibitors. You can also receive an implantable cardioverter defibrillator. So that is something that goes in your chest. It detects an irregular heart rhythm. It sends electrical impulses to get you back to that normal, love dub heart rhythm. Finally, if it's a severe case of dilated cardiomyopathy, you may require a heart transplant. Those who receive this prognosis usually also receive a prognosis of 5 years to live without a transplant.